Hello, everybody. Hope you guys are having a good day so far, and apologies for getting the next video on board. Been busy with other stuff in life, and so had a bit of things to catch up. Anyway, um, let's look into the dental caries. So I made this PowerPoint based on our existing the new 2026 therapeutic guidelines, and as well Evans article. That's a widely reputed article uh, which talks about identifying dental caries and universally accepted. So let's take it from there. Now, when we look into this here, what are we learning today? Is we are understanding the histological and microbiological pathology. That's one thing, the causative organisms and all that stuff, followed by the ICDA system and radiographic criteria when you're going to explore, when you're going to do the remineralization, how are we classifying the dental caries, and assign a formal caries risk status. So identifying a patient who is at low risk, medium risk, or high risk, that's one thing, and appropriate fluoride applications based on therapeutic guidelines. Now, to start with, the beginning of the story, uh, when we look at caries, it's basically caused because of microorganisms. Being dentists, all of you know that, and also all of you know which are the most common bacteria which causes dental caries. Now, when we look into the microscopic features, so the most commonly we come across Streptococcus mutans, lactobacilli, and the culprit here is most often it's the fermentable carbohydrates which are in the form of sucrose, fructose, glucose, because they get metabolized and form into lactic acid. Now there is a curve, like a graphical demonstration, which is popularly called as Stephen curve. Basically, what that curve talks about is the pH generally drops below the critical threshold rapidly, especially after someone has a high intake of sugar. And it takes at least 30 to 60 minutes to recover via salivary buffering, provided all the conditions are normal. The patient's having good salivary flow and everything. So you have a piece of chocolate or some sugary stuff which you eat, and then later on for the oral cavity to get back to its normal pH level and everything in a healthy mouth, it takes about 30 to 60 minutes. So that's why there is one of the most popular MCQ, which basically says that frequently consuming sugar is more dangerous for or main cause for dental caries. With that being said, we need to know what's the pH threshold. So for enamel, it's about 5.5, and for dentine, it's about 6.2 to 6.7. It's applicable for both dentine and cementum. Again, this is a good formula, and I don't think anyone remembers this, but the key takeaway from this formula is that you can see that there is demineralization in the process of demineralization, which there is a lot of calcium and phosphate which has been lost, and vice versa, the remineralization process, which happens because of fluoride applications, there is formation of fluorapatite. Now, when we look into the critical pH of a fluorapatite, we can see that it's at 4.5. So basically 4.5 means it's more resistant to caries than the normal dentine or enamel. Now let's look into the ICDA system. So all this comes in with inspection of a clean, dry teeth is a gold standard. Okay, and it also mentions that avoid using sharp explorers. Now, this ICDAS is classified from 0 to 6 on a scale of 0 to 6, and then 0 indicates a sound tooth surface. Now, ICDAS 1 is first visual change in enamel when observed in a after drying that area. So that's why I highlighted this. So there's a key difference here. The first one, ICDAS 1, is the change in enamel you see when the tooth is in the dry state. And the next one is, I say it is classified as ICDAS 2, where there is visual change in enamel, where you can see some white or brown spots, and they're visible when the tooth is wet. Okay, now in the exam, they've given you a question and a scenario where it talks about, oh, I got a patient here, and after drying the tooth, after drying the surface of the tooth, when we notice that the enamel is got some flakes, when they're specifically mentioning about drying, and you see that it's not too much of what do you say, too much of destruction happening, that could be ICDAS 1. So just keep it on the back of your hand, all right? Followed by there is ICDAS 3, which is localized enamel breakdown, where you can see microcavitation, and there is no visible dentin yet. So there is cavitation, microcavitation, but the dentin is not showing yet. Now, ICDAS 4 is, you can say that this is sort of like a borderline uh, when you're considering exposure to dentin or not. So here, when you can see there is a dark shadow from dentin, because you know that enamel is more translucent, dentin is more opaque. So when you see that there's a lot of loss of enamel, you can see the dentin, which is more opaque. So you can see the shadow of dentin, and with or without localized enamel breakdown. Now the next one is 5, which means there is a distinct cavity with visible dentin. So enamel's gone, you can see the dentin, so that's 5. 6 means extensive distant cavity with visible dentin, so involving more than half the surface. So this is clearly quite extensive, and you have to identify the tooth based on that. So whenever you see a picture of a tooth, just first thing which should come up onto your mind is this ICDA system. So first have a good look, see the enamel is visible. I would like to take it from backwards from ICDA 6 rather than going from 0, because most of the time they will give you some tooth which is having some issues with the enamel and all. So just go from 6, and also always remember the 4 is the borderline bit where the destruction is close to dentin. Now these images are from the therapeutic guidelines, and you can see there's a beautiful image here. The left one shows the initial caries, which is could be assessed as 1 or 2, and then the extreme end of the spectrum, these are 5 and 6, where you can see there is severe destruction, and obviously you can see that there is a lot of plaque accumulation, there is uneven enamel, and you can see obviously the dentin is hidden inside the plaque. So yeah, based on this, have a look around, just Google more images and try to test yourself. I think that's a good way of learning. So one, you can see that there is not much there. There you can see literally not much. So 0 was nothing. 1 is there is slight, um, like imagine like pits and fissures and those kind of things. Now that was Caries classification, ICDAS, right? Now let's look into the radiographic diagnosis. Now, the most common radiograph which we use for caries, for detection of caries, is a bitewing radiograph, where you can see that they're classified from 0 to 5 here. And then again, it starts with the minimal one where there is no radiolucency evident, and you're just monitoring the lesions in that case. So when you can look into the C1 and 2, you can see that it's outer half of enamel, 2 is inner half of enamel. So it's still in enamel, the radiolucency. And if you look towards the right, it still says preventive care. So first one is monitor, second one is preventive care, third one is still preventive care. Now I've highlighted C3 here. This is important because radiolucency extends just beyond the DEJ. So you can see this is a bit vague here. So there is preventive management unless high risk. So here you got to remember there are two factors added here. The patient is considered to be high risk patient, and the radiolucency indicates that the case is just extended beyond DEJ. So it's up to you. So based on what type of clinical features and what type of details are given, based on that you have to make a decision. Now the next one is radiolucency in the outer third of dentine, where you have to go for a restoration. Now remember this, radiolucency outer third of dentine, here you're just going with the restoration. Now C5, here you're seeing that radiolucency in the inner two-third of dentine and may reach pulp. So basically it's very close to the pulp. That's when you need to do the operative intervention. So you have to explore, use remove the caries and then do the filling. Risk assessment. So this is how you assess. So we were talking about patient being at high risk. So how do you know that the patient is at high risk? So when there are few factors here. One is there are visible cavitations or active white spot lesions, and there are so you have to look into these factors. Okay, approximal radiographic lesions which are from C1 to C5, and patient had any restorations undertaken which have been less than 3 years. Now the risk factors you have to consider. So when you take a diet chart or you ask for take the patient diet history, if the patient says that frequent snacks more than 3 times a day, that's a risk factor. And there is inadequate salivary flow or hyposalivation, or they have a medical condition which is causing hyposalivation, that is considered to be a risk factor. When there is heavy plaque accumulation, that's a risk factor as well. Patients not maintaining oral hygiene, those kind of things. Now look into the protective factors. So here the protective factors are fluoridated water supplies. Um, in Australia, there is water fluoridation, fluoridated water supply available everywhere. Okay, there is no more use of fluoride tablets anymore. So don't don't forget about fluoride tablets. Then there is fluoride toothpaste. How the patient's using are they using fluoride toothpaste? Because there are some variations, and I come across people who say that I don't like to use fluoride because um, they their interpretation of fluoride is this is actual thing where I heard from one of the person I met that the Nazis used to put high fluoride concentrations to kill people in rivers and all. That's why fluoride is toxic. That's their version. And obviously, as a professionals, we are not debating what they want, but our intention is to give the appropriate treatment, and also while also we understand the patient. Okay, so we apply professional topical fluoride, adequate saliva flow, use of xylitol gums or mints. These are our general good things which we follow. Now, some of you might already been thinking, oh, what would you do if fluoride is not there? So in the therapeutic guidelines, there is an alternative given if patients who don't know what to use fluoride. So we'll get into that point soon. Now, risk factors. Now, risk status. So how do you know someone is a low risk, medium risk, or high risk? So you got these criteria, and how often will you recall based on the risk factor. Okay, there are no clinical signs. The bitewing radiography says less than or equal to C3 level, and you see the patient has got less than one new lesion per year if it's a regular patient. uh, and there is, when you compare with the old radiographs, there are no progression of old lesions, then the patient's considered to be at low risk. Now, the medium risk, there is no cavitation, there are pits and fissures which you see, and C4 uh, radiographic lesions which are less than or equal to 4. One new lesion per year. So again, patient is a regular visitor that comes back to you. He had previously had 3 active caries lesions. Now he's having 5, let's say. Then that's a medium risk. And there is progression of existing lesions. So always with the caries, you're comparing the old radiographs with the new ones, or old intraoral photographs with the current photographs, just to get an idea if the lesions are increasing in number or increasing in size and all those things. Now, high risk patients who are untreated and they have extensive white spot lesions and bite wings are C5, and you can see that there are more than one lesion per year. So Caries Management System, you got these 10-step protocols. You can have a look into this. Always when this is important, especially when you're taking the history. So diet assessment, frequency of sugar intake, plaque assessment, bite wings, diagnostics, uh, having a tailored plan based on what you see. And also you have to be able to explain the risks, followed by oral hygiene coaching. Modified pass method of toothbrushing is one of the most widely accepted one. Professional topical fluoride applications. As dentists, there are we will come across the fluorides later on. So there are patients using fluorides, and there are professionally applied topical fluorides. And monitoring, how often are we monitoring the patient? That depends on the risk of caries. And have a program in place, like an established recall program with the patients. Now, this is all extracted from the Evans article. So this is from the Evans article. So you guys can find this one. Just Google it. You'll find it. It's very easy to get hold of the Evans article, right? Now this is the diagrammatic representation of C1, C2, C3, C4, C5. So you can see that. I'll just walk you through C5. You can see that it's in the inner two-third, and you can see there is a cavity there. So this one says that it needs urgent attention. Now we got the fluoride toothpaste. Now, this is from Therapeutic Guidelines, all right? And the good thing is people who are following the old Therapeutic Guidelines and moving to the new one, the good news is it hasn't changed. So you can still remember your old tables, which is good, yeah? So I'll keep it uh, very short in this one. It's all about memorizing. So less than 18 months, low risk, you're giving twice daily toothbrushing with no toothpaste. And elevated or high risk, if you think the patient could be at high risk, then twice daily brushing recommended. Now, this is something which is not clear in therapeutic guidelines. They said twice daily toothbrushing. It would have been nice if they put at least some form of information like with toothpaste, without toothpaste. If it is with toothpaste, uh, is it the child toothpaste? So I would assume it would be about the child toothpaste, right? Now, 18 months to less than 6 years. Normally, any kid less than 6 years, you always go with 500 to 550 ppm. Most of the time, you get these questions. A preschool aged kid. Preschool means that person is definitely less than 6 years. Okay. And then that's a hint. And then you follow, okay, this is a high risk patient. Okay, then we can give 1000 ppm, an adult strength toothpaste. Now, from 6 years to adolescents, you can use 1000 to 1500, and even adult as well, 1000 to 1500. But the only difference is if you identify the 6 years to adolescent age people to be at high risk, uh, you can recommend them more frequent use of 1000 to 1500 ppm paste or a 5000 ppm toothpaste. Now it's an adult, you got no other options, just go with 5000 ppm. And you know the general advice, you ask them to spit and do not rinse after brushing. I would like to know actually how many of you, maybe leave it in the comments, how many of you actually spit and not rinse? I would love to know. I'm really keen to know the percentage of people who actually do this, because you guys are dental professionals, so you should be doing that. But still, let's say, I would love to know, really. Yeah. Now the next one is professional fluoride applications. So what are we doing here? We got fluoride varnish, we got APF gel, we got neutron fluoride gel, we got silver diamine fluoride. Yeah. So fluoride varnish, just remember the concentration. That one's got in clinically, that's the one which got the highest concentration of sodium fluoride. So that's 22,600 ppm or 5% sodium fluoride. It's the first line of choice. Okay. So you just put it on, basically painting it on dry teeth. Apply it 2 to 4 times a year based on the risk. Yeah. And then there is APF gel, 12,300 ppm. Now there is an age consideration here. Always use it in patients who are over 10 years. It is used in the trace and it's got low pH. And again, another thing you have to remember is because this is acidulated and low pH, you do not want to use it on restorations which are shiny, like porcelain, composites, or GIC restorations. Now the safe one is the neutral fluoride gel because it's neutral, 9000 ppm. Again, over 10 years old, and it's safe to be used on all dental materials. And it's also safe to be used in patients who are having a dry mouth. Next one is silver diamine fluoride. We use this as 38% SDF or 44,800 ppm of fluoride. So this one is used to arrest active lesions. Stains demineralized tissue back, ideal for root caries or pediatrics. Apologies about my earlier statement. I was referring to most commonly used ones. Fluoride varnish is the highest concentration, but as I mentioned earlier, the silver diamine fluoride, it's only used to arrest active lesions. So just be mindful of those points, right? Now we got more supplemental home products for high risk patients. So we got the mouthwash, which is 220 ppm sodium fluoride. Again, all mouthwashes is about 6 years. Okay. Now the way you use it is rinse for 1 minute at a separate time from brushing. So this has been added. Previously, there was no clear information about when to use the mouthwash, but they're saying most people think, okay, I brush my teeth, then I use my mouthwash. Now they're specific. So your oral hygiene, you're doing it on a routine basis. Mouthwash, you can use it at a separate time when you're not brushing, like around midday, when you're at work, when you're doing something, or in the evening. So that's the daily mouthwash. Now there is a weekly mouthwash which you're supposed to use weekly. So you see, look at the concentration, it's a bit higher, 900 ppm sodium fluoride, which is again over 6 years old, and you have to rinse it for 1 minute weekly. CPP-ACP, commercially available as tooth mousse, and you basically are applying to the non-cavitated white spot lesions twice daily after regular brushing and leave it undisturbed. So once you're done with the toothbrushing, you got patients got any white spot lesions, you can suggest them to just apply it on that area and then leave it as it is. No spitting, no rinsing. Then chlorhexidine mouthwash. It is used only for very high risk patients, like cases like hyposalivation and short-term use to reduce the Streptococcus mutans load. So in these very specific cases, you're using the chlorhexidine mouthwash. All right, now we're having a short break. So during this time, I just wanted to inform you guys that at the end of this PowerPoint, I just put some 15 multiple choice questions for your self-assessment. Just try to assess yourself and pause the video before you start answering, because the next slide will be, you'll be having the answer. So I just put very minimal, about 15 questions, just to encourage you guys. That's it. All right, let's continue. So this is from the therapeutic guidelines. All of you got access to this, I believe. If not, you should have it. Uh, I've been fortunate enough to receive the physical copy. I like the books, not the online version. So yeah, I'll be uh, uploading more information in future if I think there is more something important or value for you guys. So that's for toothpaste for elevated caries, and this is toothpaste for elevated risk. We already discussed this, so I'll just move forward. Now, silver diamine fluoride, 38%. Okay. Now, what's this? So it's got a combining effect of where there is antibacterial effects of silver and remineralizing effects of fluoride. So we got two components, and each of them got their own thing. So silver is actually having the antibacterial effect, and then fluoride is remineralizing agent there. So how is silver acting? Silver ions destroy the cell walls and inhibit enzymatic activity, and fluoride promotes fluorapatite. So that's the mechanism of action. So where are we using this? So we are using this in arresting root caries in the elderly individuals, and children who's got behavioral challenges, then we can use that there. And pre-cooperative children, that's you can use there. Okay. Now the only disadvantage with this one is it's actually causing permanent black staining of carious tissue. So before you are actually applying the silver diamine fluoride, you make sure that you inform the patient or the parent that this is a likelihood of staining, this is the possibility, and so that you have that informed consent. Now, patent features. Sealants, all of you know, they are the physical barrier preventing biofilm accumulation in vulnerable occlusal anatomy. So you know where to use it. So it's used in deep retentive fissures in the high-risk patients. And speaking about patent fissures, just remember that in the patent fissures, the caries is actually attached to the walls of the fissure, not on the floor. So just remember that bit. And you can also use resin based for excellent moisture control. So GIC based for erupting molars where poor moisture control. So I think this is one of the most commonly asked questions where they put you in a situation where you can assume that moisture control could be an issue based on the location of the tooth or just a newly erupting tooth like that. So in that case, you can go with the GIC. Now, just recently we discussed the radiographic score C1 to 5 and all that stuff. So this is diagnosis and management. I think it's part of your assessment cluster. So what are we doing here? So would like to go from backwards. So 5 and 4, C5 and C4, you are restoring it immediately. Yeah. And C3, you're restoring if cavitation is suspected or history of rapid progression is there. And then C1, C2, you're not restoring, you're just remineralizing. Yeah, so based on the radiographic score, just pay attention to this one. I thought it's important to have the management of for deep caries, which is falls under C5 category. So in this one, you can see that there is selective caries removal. So always remember to remove the infected soft dentine at the periphery to establish a clean bonding margin. So clinically, when you're removing the infected dentine, you must have that feeling of the DJs feeling a bit harder. You can always leave the leathery dentine and demineralized dentine over the pulpal floor to prevent pulp exposure. Now there is another method which is a stepwise excavation, which is a two-stage removal. So the first stage involves partial removal and just dealing with GIC on a temporary basis. So what's happening is GIC it allows formation of the reactionary dentine. So you leave it in there for about 6 to 12 months, and then followed by stage 2, you get in there and you remove the residual caries and place a final restoration. So this is very important. Next one is direct pulp capping. So if a pinpoint exposure occurs in an asymptomatic clean field, so let's say you're doing this clinic in the clinical environment, if you accidentally expose a pulp and then it's and you consider that it's in clean field, you can always use the MTA or calcium silicate cements. So this slide is of much value. So I think there are different scenarios in this covered. So go through this repeatedly. feel free to take a screenshot. I'm not restricting or copywriting anything here. All for you guys. Now the recall schedules. So we're done with that bit, the clinical stuff and everything. So how often are we having this recall? Generally, no risk or low risk patient, 12 to 18 months. And bitewing radiograph frequency is always in the first visit, then every 12 to 24 months. So anytime, remember, if it's a new patient, you're taking a bitewing radiograph, irrespective of their caries status. Now, medium risk, 6 months, where you're asking them to come visit every 6 to 12 months. And then the high risk, you always recall 3 months until you're confident that the risk level went backwards. From high, they went to medium or low. Until then, until you're satisfied, you ask them to visit every 3 months. See, that's what it says here. First visit, then once you stabilize, once you are in the process of stabilizing, then you can go 6 monthly until downgraded. Now, summarizing the information of what we went. So caries is a biofilm mediated disease managed medically before surgically. So enamel critical pH is 5.5 and dentin is 6.2. And C3 lesions are generally monitored in low risk but restored in the high risk patients. And then the prescribing rules of toothpaste, CPP, ACP. Yeah, one thing I didn't mention earlier is ensure that CPP, ACP is avoided in patients who are allergic to dairy products. And APF gel, we already discussed that you avoid it on any ceramic restorations or like veneers or GIC restorations. What it does is basically it makes the surface rough. And so the restoration becomes more plaque retentive, and then it's not good for your oral hygiene. All right, quiz time, guys. So as I mentioned earlier, you got 15 MCQs, and I hope you are ready. Or you can pause this video and then play it at your own pace. Okay, what I'll do is I'll just move it forward slowly, and then you can pause and do your self-assessment. Good luck, and I'll see you next time. Awesome. Thank you for holding on to this, and I hope you found some value for this. Please share this with your friends and everyone who you think can benefit from this channel. Thank you very much. See you next time.